The topic we will be discussing is the building the basics of coagulation based upon some of the case what we have evaluated in our laboratory. So when we talk about coagulation, it appears to us as if we are into a very confusing state, and the state of confusion can be reflected very well in this picture. Whenever you look into lots of railway crossings and they are crisscrossing each other, and you don't understand which train will go in which way. It is very similar in coagulation. So whenever we deal, we land up sometimes or many times in a confused state what actually we are dealing with. So that's the reason coagulation appears many times to us as a conundrum. And why this is? Because the reason is not that you can say the reason is not that related to the hemostasis per se, but it is about how we have been trained in coagulation. And in coagulation, there is less emphasis has been given during our undergraduate curriculum. And if we ask, I will ask anyone that can you recollect your MBBS coagulation class? I'm afraid how many of you can recollect your MBBS class? Again, in postgraduate teaching, still we ignore bleeding disorders or hemostatic or thrombotic disorders. And the biggest part is that very less of us actually go into the lab and do a manual coagulation testing by our hand. And so that is almost we usually avoid doing a practical testing. And there is a less laboratory and clinical interaction. And that is the reason to understand the basics of coagulation and the pitfalls of coagulation testing is less in many of the practitioners or in many of the laboratories. And we need to understand also that the tube is not the body. That is very important. So if we don't understand the coagulation in a proper way, there is a chance that there will be misinterpretation of the results, and misinterpretation of the results will lead mostly to the cancelled procedures and surgery, can be inappropriate management of bleeding conditions or thrombotic conditions, which may be sometimes life-threatening to the patient. There will be wastage of resources. Can you imagine if you are giving somebody who is actually not requiring a cryoprecipitate or FFP, there is those cryoprecipitate FFP are getting a waste. So there is wastage of resources, and there is also a risk of patient to transfusion transmitted infections or TTI. And whenever the scenarios, the situations arises, always you will find that there is a argument between the clinician and the laboratory, and each of them will be putting the blame on each other. But can you imagine the condition of the patient who is standing outside and asking for the help because he requires the same kind and similar kind of service wherever he goes, irrespective of whether the clinician is blaming the laboratory or laboratory is a clinician. And it is our duty that we should be aware of the pitfalls in coagulation and give best service to our patient. And it has been rightly told that if you look at the mountain from far away, it will appear very beautiful. But if you go near, and you can find the miseries of a mountain. So with this, what is required being a laboratory person, we should have a good bleeding history, relevant clinical details like a liver function test findings. Treatment details are very vital, that is anticoagulants, FFP transfusions, or factor concentrates. And nowadays, eculizumab is being used in case of hemophilia A patients. And for you, I can give an example. Yesterday, we had a discussion regarding on a seminar of eculizumab. So what a laboratory person should insist on, a patient who is on eculizumab therapy, they have to ask that the treatment history should be communicated to the laboratory. And there is a good chance in hemophilia A patients, you may get a normal APTT, And if you are doing a clot-based assay, even a factor 8 labels will be erroneous. So those cases you may have to look for some other modality of looking at doing a factor 8 assay, maybe a chromogenic based assay, wherever there is a requirement. So treatment details are very vital. And again, time and type of sampling is also very important in case of a coagulation workup. Because it has been recommended that all coagulation testing must be performed within 4 to 6 hours of collection. If you are going for a sample that is being processed after a few days, you have to separate the plasma and freeze it or froze it immediately in minus 80 degrees centigrade, and then you can thaw it and test it later on. Otherwise, you have to perform all your tests within the time frame of 4 to 6 hours. So Dr. Oscar Rambo has correctly said a mistake conception prevails among the clinician that the pathologist, given only a piece of patient's tissue or a few ml of the blood, has all of the other ingredients necessary to produce a statement of absolute truth at the end of this report. And it will be more hazardous if we pathologists carry the same belief, and it is going to be very problematic for the patient. So what we have should remember is that just a sample or just a tube or just a result is not a solution to the patient. So we have to give solutions to the patient, not a test report. So coming to our case studies, I'll be having a series of some 12 to 14 case studies. Hopefully they will be interesting for you. So the first case, case 1. Sorry. The history goes like a 37-year female, and she presented with menorrhagia since 6 months, last 6 months, which is associated with clot and flooding. And she has taken some hormonal therapy and antifibrinolytics like tranexamic acid. She was born of consanguineous marriage, non-consanguineous marriage with no significant family history. And she has one daughter and one son, and there is no abortion history, and both the pregnancies were uneventful. And if you look into the laboratory investigation, so there is a battery of tests has been done, and it has been extensively worked out. You can see the bleeding time is 2 minutes 15 seconds, which appears normal. Hemoglobin is 11.6. Platelet counts are normal with 343,000. Prothrombin time, APTT, TT, fibrinogens all appears to be normal, though fibrinogen mild elevated, but it is not reduced because bleeding is expected to have either hypofibrinogen or fibrinogenemia cases can have bleeding manifestation. Factor 8 also appears to be mildly elevated, but it is again not reduced. Factor 9 is again normal. You looking at urea solubility test is negative, and doing a platelet function test all appears to be within normal limits, and von Willebrand factor for recurve is 107 and for antigen is 120. So with this clinical history and the case being extensively worked out, you can understand that we couldn't ascertain a hemostatic abnormality in this case. But the bigger question is that do we require to do so many tests in these cases? Or is there any simpler approach where we can simply decide whether to test or not to test for a bleeding disorder? So for this, one need to answer first the 5 questions, which is related to your history. First one, decide whether patient is a bleeder or not a bleeder. Once you think that patient is a bleeder, try to decide the severity of the bleeding. Is it a mild bleeder, moderate bleeder, or a severe bleeder? Next, what type of bleeding disorder is it? Is it a primary hemostatic disorder? For your knowledge, all primary hemostatic disorder usually present with mucocutaneous bleeding. Or is it a secondary hemostatic disorder? Secondary hemostatic disorder are resorted to your coagulation factor deficiencies. They usually present with deep bleeds, means joint bleed, muscle hematoma, deep abdominal bleeds. So those will be there. Or is it a vascular disorder or any combination of primary and secondary hemostatic disorders? Once you have decided that this is a primary or secondary or a combination of this, you have to say whether this is an acquired bleeding disorder or inherited. If inherited bleeding disorder, is it a recessive or dominant or X-linked disorder? If you answer all these four questions, 95 to 99% cases, the clinical diagnosis will be in front of you. Then you can do a screening laboratory test or discriminatory test or definitive test to establish your diagnosis. So what is important in those 5 questions what we have discussed is about the clinical history and the examination finding. And remember, in bleeding disorders or in thrombotic disorders, you need to have a systematic approach to elicit and interpret all relevant information. So you cannot skip any relevant history and go directly to investigation. You will end up in doing an n number of investigation. At the end, you have to tell the patient or release the report that we could not find any hemostatic disorder. So what are those systematic approach? Is there the evidence of subfluid bleeding? Is bruisability, menorrhagia? These are examples of subfluid bleeding. It can be extensive, and you have to discuss extensively with your physician and the patient to ascertain that there is subfluid bleeding are there. Is there any manifestation of severe hemorrhagic disorder? They have significant abnormal history of bleeding, either spontaneous or after trauma or after intervention, for example, biopsies or surgical procedure. You have to also evaluate the absence of prior bleeding. Is it important to determine that whether or not the patient has been exposed to significant hemostatic disorder like a dental extraction, like surgery, trauma, childbirth? So if there is a significant bleeding happened during those procedures, so that can be a significant clinical history for you. And what is the objective confirmation that there is a bleeding event is there and it is severe in nature? So any bleeding that requires a blood transfusion as per the standard guideline is a severe in nature. Any bleeding that leads to development of anemia that requires iron replacement therapy. If bleeding is so severe that patient need to be hospitalized, and the results of laboratory tests that has been done previously provided all the pre-analytical and analytical variables have been taken into account during reporting of the laboratory results. Again, medication history is very important. Nutritional history is also important, where you have to look for a vitamin K deficiency or vitamin C deficiency, and also general nutrition or general socioeconomic status also is important. For an example, a patient comes to you and has a complaint of gum bleeding, coming from a low socioeconomic status. Patient is suffering from a bad oral hygiene. So if there is a bad oral hygiene, that can be a gum bleeding. It may not be a bleeding disorder. So these things are very important. Then what are the sites that shows bleeding? A distribution is why it is important. A localized bleeding are mostly acquired in nature. A generalized bleeding, multiple sites being involved, are more commonly of coagulation disorder. Similarly, mucosal and cutaneous bleeding can also occur in some of the vascular disorders like hereditary hemorrhagic telangiectasia or scurvy. Next, last but not the I can say most important is a detailed family history that includes consanguinity. So never forget to ask about the history of consanguinity, because in the presence of bleeding with consanguinity history, the type of bleeding disorder you might be dealing with makes it an autosomal recessive in nature. Okay, so these are very important things. So there are some specific bleeding manifestations are there that can indicate you or help you in deciding what type of bleeding disorder it can be. Like I have already told, mucocutaneous bleeding is because of a primary hemostatic disorder. It can be because of thrombocytopenia, platelet dysfunction, or von Willebrand disease. There can be mild spontaneous bleeding or injury-related bleeding can be related to secondary hemostasis, usually mild and moderate, like a von Willebrand disease, hemophilia A, B, other factor deficiencies, etc. Sepal hematoma, hematrosis, hematuria, intramuscular bleeding, intracerebral bleeding, retroperitoneal hemorrhage indicates deep bleeding, like a severe hemophilia A or B, or it can be a severe type 3 von Willebrand disease, or it can be a afibrinogenemia. Similarly, umbilical storm bleeding, delayed wound healing, habitual abortion, you have to look into fibrin stabilizing factors like factor 13 or fibrinogen and hypofibrinogenemia or dysfibrinogenemia. Impaired wound healing, factor 13 deficiency, facial purpura that can be seen in case of a GT or glandular thrombocythemia or severe thrombocytopenia. Recurrent severe epistaxis and chronic iron deficiency, you might be dealing with a hereditary hemorrhagic telangiectasis. So when I say about all these bleeding disorders, my question to all of you, my friends, is that what is the most common cause of bleeding manifestations? And it is the acquired bleeding disorder. So the acquired bleeding manifestations are more common. So you have to first think of acquired bleeding conditions if the patient is presenting with an adult age, if patient is presenting as an acute onset bleeding, patient is presenting with a localized bleeding, etc. So there are battery of causes are there. But in a critical scenario, you have to be suspicious of DIC, thrombocytopenia, liver disease, etc. But when we talk about inherited bleeding disorder, remember inherited bleeding disorder are rare disorders. But yes, you have to have a very good of suspicion depending upon the clinical history to ascertain the cause, whether it can be an inherited bleeding disorder. And whenever there is an inherited bleeding disorder, the pattern of inheritance can be either X-linked, autosomal dominant, or autosomal recessive. And we many times face a lot of problem in remembering which one is autosomal dominant, autosomal recessive, or X-linked. A typical history of male members are being affected, female is carrier is X-linked. And which one is your X-linked bleeding disorder? Hemophilia A and hemophilia B. Then you have other three causes of bleeding manifestations. Either it can be a primary hemostasis. Primary hemostasis is because of platelet or platelet dysfunction, von Willebrand, or fibrinogen. Or it can be a secondary hemostatic defect is because of your coagulation factor, or it can be blood vessel. Remember, all coagulation factor deficiencies are usually, except your hemophilia A and B, are usually autosomal recessive in nature. And all platelet dysfunction are usually again autosomal recessive, though there are some variations can be happen in glandular thrombocythemia or Bernard-Soulier syndrome. Another exception, only factor 11 deficiency can be autosomal dominant in nature. Von Willebrand, depending upon its type, can be dominant or can be recessive. So coming back to our case 1, the clinical history, I have already told. With this, can you decide whether the patient is a bleeder or non-bleeder? What is the severity and what is the primary or secondary, acquired or inherited? So if you think of bleeder or non-bleeder, query bleeder, the bleeding manifestations are just acute onset manifestations at the age of 37 years, only menorrhagia is there. Put it top, don't you? Only bleeding so it can be a query bleeder. So I don't feel it as a bleeder patient. Then looking into the manifestations, it looks like a mild. The only menorrhagia is there. So primary looks like acquired. Clinical, if you think, it mostly looks like either a localized cause, that can be a uterine fibroid, or there can be some hormonal causes might be there. Somebody is scratching on my screen. Okay. So with this, what is the diagnosis? The diagnosis is there is no hemostatic defect that is identified in this workup. This case actually highlighted a bigger question can we have avoided so extensive workup in this case? So let's go to the second case. The history goes like a 18-year-old female with heavy menstrual period, same menorrhagia since menarche. So from the time patient achieved the menarche, patient had menorrhagia. Typically, it lasts 8 to 10 days with heaviest bleeding being on the day 2 or 3. And there is iron deficiency since menarche. Excessive bleeding follows extraction of the wisdom teeth at the age of 14 that required a return to the dentist, so that requires suturing. Bruises, she bruises very easily. Her gums bleed during brushing, but significant is that she was born of non-consensuous marriage and there is no family history of bleeding. So if I will ask, decide bleeder or non-bleeder, patient is a bleeder. Decide the severity, looks like a moderate to severe bleeding manifestations. Looking at the nature of the bleeding, primary bleeding hemostatic disorder, looks like inherited, early age or onset, menstrual history, common coagulation bleeding or global coagulation bleeding manifestations are there. So looking at all the history, the possible clinical diagnosis is query von Willebrand disease. So we did the laboratory investigation. Bleeding time is prolonged, 6 minutes 30 seconds. Hemoglobin is 9.6, is reduced. PT is normal. APTT is mild increased APTT. So can anybody say why APTT is increased in this case? Are we dealing with anything that is related to hemophilia or A or B? Answer is APTT is reduced, APTT is prolonged in this case. Possibly there is a chance that factor 8 could have been reduced. Why factor 8 could have been reduced? Factor 8 is being carried by von Willebrand factor. And the von Willebrand factor usually increases the half-life of factor 8. In the absence of von Willebrand factor, factor 8 might be reduced. And once factor 8 is reduced, it will be reflected as a prolongation in the APTT. Thrombin time is normal. Fibrinogen is 297. Factor 7 levels are 48.4. So that is marginal. Factor 8, so not 7. 8 is marginal. Factor 9 is normal. Urea solubility is negative. And we did a platelet function test and there is absent aggregation to ristocetin. So that indicates it can be a von Willebrand disease or BSS. Looking into von Willebrand ristocetin cofactor activity, it is 22%, and von Willebrand factor antigen is 27.6. But the antigen and Ricoff and antigen ratio is 0.6. So with this, what is your diagnosis? Von Willebrand disease type 1.
WD.
Yeah, anybody wants to say anything or ask anything? Okay. So I'm not going into details of all the von Willebrand disease, but there is a simple approach. How do you approach a von Willebrand disease? With a mucocutaneous bleeding and high index of suspicion of von Willebrand disease, you have to do von Willebrand standard testing. What are the standard testing? Standard testing are antigen, ristocetin cofactor activity, a factor 8, and platelet count. If your antigens are severely low, means less than 5, you might be dealing with type 3. If your antigen and Ricoff ratio are more than 6, it is type 1. If it is elevated, you might be dealing with type 1C, with the propeptide levels of von Willebrand getting elevated. Similarly, coming to if your ratio is less than 6, so what you are using Ricoff to antigen. Ratio more than 6, possibilities are 1 or 3. If ratio is less than 6, possibilities is the von Willebrand type 2. So you have to look into multimers. Multimers are normal, then 2M. Multimers, that is loss of high molecular weight multimers, then there are two possibilities. Either you are dealing with a 2A or 2B. If you are doing a RIPA is a low dose ristocetin induced platelet aggregation. Usually 2B shows a lot of propensity for risto to aggregate the platelets. In a low dose, normally what happens, you should have an absent response. But in a 2B with a low dose ristocetin, you will see that there is some response to platelet aggregation with ristocetin. Then you might be dealing with a von Willebrand type 2B. If they are normal, you are dealing with type 2A. Other way around, if disorders with von Willebrand factor binding to factor 8, that is 2N disorders, you will find that factor 8 is disproportionately low compared to von Willebrand factor antigen. So in those scenarios, you have to do a factor 8 binding assay, and you might be dealing with 2N. 2N is not that prevalent in India. So why I have presented this history to show you that 1 in 1,000 individuals might be having a bleeding disorder among the female. Most of them don't know that there is a bleeding disorder. And when should they be concerned of having an abnormal bleeding? So that is the biggest question. So it led to the thought process, is there a way we can objectively actually assess the bleeding manifestations? For this, the ISTS SSC has proposed a bleeding assessment tool, PAT. I have tried to put it in a summary way. If anybody is interested, can refer the article that has been put below and go and can download the complete set of questionnaire for bleeding assessment tool. It is usually consists of 14 questionnaires, and depending upon the bleeding manifestations, they can be scored 0 to 4. So a maximum score of 56 is possible. A minimum score will be 0. And what are those 14 questionnaires that is being asked whenever you have a bleeding patients? Epistaxis, number 1. Number 2, cutaneous bleeding, bleeding from minor wounds, oral cavity bleeding, GI bleeding, hematuria, tooth extraction, surgery, menorrhagia, PPH, muscle hematoma, hematorosis, CNS bleeding, and any other bleeding manifestations. So if bleeding manifestation is absent for any bleeding, it is 0, or trivial, it is 0. If bleeding require only consultations, who does not require consultation, but there are more than 5 episodes in a year or more than 10 minutes of epistaxis, something like that, you can score it 1. But bleeding is such intense that it required consultation only without any intervention, you can put a score of 2. Whenever there is an intervention is being required, but that does not involve blood transfusion or replacement therapy or desmopressin therapy, you can put a score of 3. Any bleeding manifestation that require transfusion, replacement therapy, desmopressin therapy, etc., or surgical intervention or suturing, etc., you can put a score 4. Using this scoring system, what is a significant bleeding score? If you are dealing with the children, if the score is more than 3, it is a significant bleeding score. More than 4 in male and more than 6 in adult female. And it is a very sensitive tool, and research is showing that it might replace your conventional approach of deciding whether the patient is a bleeder or non-bleeder. So what you have learned, that a thorough history taking is vital and the best screening tool, and ISTS SSC BAT is an objective tool for assessing bleeding. So how do you then assess an abnormal PT or APTT? So whenever you have a PT or APTT sample, a result are abnormal, these are the minimum questions you should ask before you sign out a report. When was the sample being drawn? Because a delayed sample, that is a sample that has been stored or that has been transported, the integrity of the sample is questionable. So PT and APT results are questionable. You might have to get a repeat fresh sample. Does the patient's clinical profile fit to your findings? Do other tests relate to this abnormality? Is that a real or an artifactual result? What is the hemoglobin level? Can anybody say what is the hemoglobin level is important by in abnormal PT or APTT? Okay, we will come to it in one of our case. Was it a line, central line or peripheral line sample, or a sample that has been collected where the saline is being infused from the same hand? Any other interfering factors like a hemolysis, lipemia, icterus, Hill samples. Do I need to do a mixing study? Remember, never ever treat just a test or just a test result. So coming to the next case is a 45-year-old lady. Renal biopsy was planned. Hemoglobin was 12.2 gram per deciliter. Total leukocyte count was 5,500. Platelets are 2,10,000. A PT and APTT that has been done. APTT seems to be prolonged. That is 66.8 seconds. So as usual, the surgeons or the nephrologists have given FAP, and they found that normal APTT was achieved and the procedure was carried out safely. But after the procedure, again, when APTT was repeated after some days on a OPD follow-up for a referral workup, it is being found that again APTT is still prolonged. And when mixing studies have been done, it suggested a possibility of factor 11 or factor 12 deficiency. So how mixing study you have to interpret, I will come to it. But the most important thing was that patient never had a history of bleeding. So factor 12 assay was performed and it was found to be 2%, where normal value is 50 to 150. And whether you are aware or not, remember, factor 12 deficiency patients do not bleed. So actually, patient did not require a FAP transfusion. So let's see why this misinterpretation has happened. Because possibly you can say, I have learned from my physiology classes or in my pathology, Robbins, or there is a coagulation cascade model is there. And what does this model say? This model is consists of an intrinsic and extrinsic pathway. The extrinsic pathway starts with a tissue factor that is activating your factor 7. That 7 will activate 10. 10 along with an activated 5 will convert prothrombin into thrombin. Thrombin will convert fibrinogen into fibrin, and fibrin is stabilized by factor 30. Similarly, intrinsic pathway, there will be contact factors that will get activated by damage to the blood vessels at the surface. And this contact factor will activate your factor 12. Factor 12 is also a kind of a contact factor. So this 12 will convert factor 11 into 11A, 11 will convert 9 into 9A, 9 along with an activated factor 7 will activate the factor 10, and 10 again will with 5 will activate form the thrombin. Thrombin will cause fibrin formation and the clot will be formed. So you can see in a simpler way, what is there? There is an intrinsic pathway where factor 12, 11, 9 and 8 are involved, along with the common pathway where factor 10, 5, thrombin, fibrinogen are being involved. Similarly, in an extrinsic pathway, there is factor 7, which is exclusive to the extrinsic pathway, followed by the common pathway. And what happens when you do a laboratory test? The intrinsic pathway and the common pathway defects are being reflected by an activated partial thromboplastin testing. Similarly, the extrinsic pathway and common pathway defects are being reflected by your prothrombin time testing. So, to say in a simpler words, intrinsic pathway or the defect are governed by your APTT test. Extrinsic pathway, that is tissue factor and factor 7, are being governed by your PT testing. And common pathway are defects will be reflected in both APTT and PT testing. So the coagulation cascade, what we have learned till now, or what we use till now, is more reflective of an in vitro testing. And it suffers from many pitfalls And what are those pitfalls? Number one, as I have showed you in this case, factor 12 is essential for hemostasis, which is being reflected in your coagulation cascade, but people with factor 12 deficiency actually do not bleed. Whenever we talk about factor 11 is the only way to activate factor 9, but the people with 50% of the people with factor 11 deficiency do not bleed as much as we are expecting. Similarly, if there are two pathways are there, so a pathway defect in the intrinsic pathway should be compensated by an extrinsic pathway hyperactivation. We are also not observing that. So that is the reason the coagulation cascade may not hold good what happens inside the body. And for this reason, currently in 2001, a cell-based model of hemostasis has been proposed, which usually shows that all the hemostasis are actually happening on the surface of the cell, and it has three pages, that is initiation, amplification, and propagation. The initiation happens on the tissue factor bearing cells, amplification on the platelet, which when it is getting activated, and propagation happens on an activated platelet surface. To understand in a simpler way, the initiation phase, whenever there is a tissue factor getting exposed by an injury, it will activate factor 7, and factor 7 will activate small amount of the factor 10, and it starts the process of thrombin formation and formation of the fibrinogen. In the propagation phase, what will happen on the platelet surface, which gives you the phospholipid and the calcium that is circulating in your peripheral blood circulation, along with your activation of, will activate your factor 11. And this factor 11 will activate 10 along with 8 will activate factor the 11 will activate factor 9, 9 will activate along with activated factor 8 will activate factor 10. So the complex of 9 and 8 together are known as teenage complex or 10H complex. Similarly, the activated 10 with activated 5 will convert prothrombin into thrombin. That's the reason the complex formed by an activated factor 10 and 5 is known as prothrombinase complex. They are two crucial, and the endpoint is thrombin generation and fibrin polymer formation. So whatever the pathway is involved, you have to remember thrombin is central or critical in the coagulation system. And other natural anticoagulants, they also come into play. They want to prevent the process. So if you look into the whole process, you can understand that the thrombin generation is important, and once thrombin is generated, the clot is stabilized, the elimination of the thrombin also, the process also starts. But I want to ask the question, where is factor 12 in this cascade or in this model? You can see factor 12 is not there. So possibly the cell-based model is a better reflection of what actually happens inside the body, not what is happening in vitro tracing like a PT or APTT. So what we have learned: investigate coagulation abnormalities thoroughly. Isolated APTT prolongation does not always indicate hemophilia A or B. Bleeding history is critical in further decision making, and FFP transfusion could have been avoided in this case if we are aware that it could be a factor 12 deficiency. Coming to the next case, a 13-month-old boy with hemarthrosis and scalp hematoma. Outside note mentions that hemophilia A with a history of two sibling sisters, they are died of bleeding manifestation within 6 months of the birth. So kindly note there are two sibling sisters, females are being affected. So whenever females and two females are being affected, you have to really question the diagnosis of hemophilia A, because affected hemophilia A usually affects the male members. Exceptions are there, that is Lyon's hypothesis, as you, or Lyonization, you must be aware of it. So the patient actually received factor 8 and FFP outside multiple times, and outside report of factor 8 was 20% by outsourcing the sample to somewhere across beyond Odisha state, and factor 8 infusion actually did not resolve or did not show any improvement. When a bleeding screening workup was done, PT was shown to be 36.7 second, APTT 74.6 second. Both are prolonged. Mixing studies with PNP showed correction of both PT and APTT. That means it is a coagulation factor deficiency, but both are prolonged. Whenever you have both are prolonged, you have to keep in mind either you are dealing with a common pathway defect or a combined factor deficiency. So we did some additional experimentation in the mixing study, that is AH serum. Where APTT was shown to be 30 seconds. That means there is a correction with the AH serum. For your knowledge, AH serum is deficient in factor 8 and factor 5. We did a correction with adsorbed plasma. Adsorbed plasma correction shows there is no correction because APTT is still prolonged, that is 70.3 seconds. And for your awareness, adsorbed plasma usually adsorbs all vitamin K dependent factors. What are they? 2, 7, 9, 10. Correct? So we did a factor assay for 2, 7, 9, 10. All those factors are deficient. So can anybody now say the diagnosis? Okay. The patient is actually suffering from congenital vitamin K deficiency. Why congenital? Because there are two family history where sibling sisters have died. That is the reason congenital. Otherwise, neonates at birth can present with vitamin K deficiency and they are being given a prophylactic vitamin K injection. So for your enthusiasm, I can say the moment we diagnosed the case, we informed the clinician. The clinician started injectable vitamin K. The next day, the baby was out of the lap of the mother, was playing happily. And the same baby has undergone a successful circumcision surgery under oral vitamin K prophylaxis. So it is very important to do a mixing study with AH serum and adsorbed plasma. Anybody in your lab setup can perform a mixing study with AH serum or adsorbed plasma. So what you have learned, misdiagnosis of bleeding disorder is common. Number 2, thorough and accurate laboratory diagnosis is vital. It may be life-saving. So this could have saved the life of that boy. History is again critical because here the history shows male and female both are being affected. So you may not be dealing with a hemophilia A. Mixing study is vital for investigating prolonged PT or APTT. And we have to think beyond hemophilia. Scenarios can come. So how do you then interpret mixing study? Do a routine testing of PT and APTT. PT, APTT both are normal. You don't need any mixing study. If PT and APTT, out of which only isolated APTT prolongation is there, it happens in case of either hemophilia A or factor 8 deficiency or hemophilia B factor 9 deficiency. Do a mixing study, complete correction. You are dealing with a factor deficiency or weak LA. Incomplete correction, possible LA will be there. Accordingly, you can do your definitive assay or or confirmatory assay. If both are prolonged, mixing study, complete correction, you might be dealing with a vitamin K deficiency factor. If there are incomplete correction, you might be have to consider go back and ask for a DOAX therapy or is the heparin therapy, etc. there or not. Accordingly, you can give vitamin K or repeat PT and factor 7, etc. And in case of a DOAC, you can do anti-10A levels or apixaban levels. Similarly, if isolated PT are, if only PT is prolonged, if both PT and APTT, it again can be vitamin K deficiency, it can be a lupus anticoagulant, all those things you have to consider and mixing study will help. So whenever you will think of inhibitor, if there is an incomplete correction happens. So just to give you an idea in a tabular format, factor 8 or hemophilia A patients will have an abnormal APTT, PT will be normal. It will get corrected with PNP, that is pooled normal plasma. It will not correct with H serum because H serum is also deficient. Patient's plasma is also deficient in factor 8. It will get corrected with adsorbed plasma because that is deficient in 2, 7, 9, 10, but is sufficient in factor 8 and factor 5. 9, the scenario is very similar to hemophilia A, that is 8 deficiency. Only change you will find that it will correct with H serum, but it will not correct with adsorbed plasma. If the correction happens with normal plasma, H serum, adsorbed plasma, you might be dealing with a factor 11 or 12 deficiency. If both PT and APTT are abnormal and it gets corrected only with the adsorbed plasma, you can think of factor 2 deficiency. If both PT and APTT is abnormal, it gets corrected only with do not get corrected with the H serum, you might be dealing with a factor 5 deficiency. It gets corrected with normal plasma and adsorbed plasma. Similarly, only PT is prolonged and it will not get corrected with the adsorbed plasma, you might be dealing with 7 deficiency. 10 will have both PT and APTT will be abnormal and it will not get corrected with the adsorbed plasma. Inhibitors will not correction with normal plasma or H serum or adsorbed plasma. So by this way, you can delineate what factor is deficient and do those factor assay directly or make your diagnosis directly whether inhibitors are there or not. So how do you prepare an adsorbed plasma? Is very easy. You just dissolve 100 milligram of barium sulfate in 1 ml of BNP, centrifuge it, take the supernatant plasma, do a PT. PT should be more than 60 seconds. Accept it. You can run a adsorbed plasma mixing study. H serum, you have to prepare 3 H serum. Allow the normal blood to clot. Serum will be separated after 4 hours of incubation at 37 degrees. Coming to the next case, 25-year female posted for appendicectomy in emergency OR in the outside hospital. Hemoglobin is 12.2. WBC count is 15,500. Platelet is 210,000. And APTT shows prolongation. Patient was given FFP. Procedure carried out safely. After recovery, sent to us for a repeat assay. So it has been done outside. So what is the repeat assay? We did a PT. PT is normal, but APTT was showing prolonged APTT or that is 44.8. I have mentioned actin FSL. Can anybody say what is actin FSL? Okay, actin FSL is a lupus sensitive reagent because it contains a low phospholipid. We did a mixing study of APTT is still prolonged. Then we repeat the test, APTT test with actin FS. Actin FS is a lupus insensitive, it's a high phospholipid content, and we found that APTT is getting corrected 26 seconds. Possibly we are dealing with lupus anticoagulant. So we advise for a lupus testing by DRBBT, that is dilute versus viper venom testing. Screen is prolonged, mixing of the screen or LA1 is also prolonged, that did not correct. Did a confirmed testing that gets it corrected and the ratio is 2.53. So actually the patient was suffering from marked positive lupus anticoagulant. The name is anticoagulant. The patient is condition is more pro-thrombotic. So this didn't actually require FFP, and FFP may be fatal in some of the cases in surgical procedure because it will prolong the it will cause thrombosis during surgery or post recovery of the surgical procedure. So what is important here is we have different kinds of APTT reagent. We must be aware whether we are dealing with a lupus sensitive or lupus insensitive reagent. And it has been recommendation is that a APTT reagent with a low lupus anticoagulant responsiveness should be used to screen for coagulation factor deficiency and heparin monitoring. And that require a continued education because many laboratory persons are not aware of these things. And in addition, it has also been recommended or prudent to keep at least 2 types of APTT reagent if you are a referral lab. For a routine factor assay and inhibitor assay and heparin therapy, a lupus insensitive reagent should be used preferentially. In a patient clinically suspected lupus inhibitor or lupus sensitive reagent should be used. And whenever you reports as a result, the clinical history of the patient should be integrated with this report, and remarks should include possible use of other tests clarifying prolonged APTT without apparent reasons or mixing studies have produced or no or incomplete correction. So what lesson you have learned? APTT reagent and test in target are important before any assay. Mixing studies is vital for investigating prolonged PT or APTT, rule out inhibitor and unnecessary FFP transfusion. Then how do you approach lupus anticoagulant? This is a three-step approach. First is screening. Screening with a lupus phospholipid, low phospholipid reagent, that is phospholipid dependency can be shown by if that is a prolonged result is there. Then duo mixing. Mixing indicates that there is an inhibitor. Confirm by enriching the reagent with phospholipid, so that can prove or establish your phospholipid dependence of the inhibitor. Guideline says that 2 tests should be done on different principle. More than 2 tests can have false positivity. DRBBT is a must. Second test can be a sensitive APTT, that is low phospholipid silica as activator. Lupus anticoagulant should be considered positive if one of them gives you a positive result. And it need to be confirmed after 12 weeks to rule out transient lupus anticoagulant. And if you have to express, you should have a local cutoff. And 1.2 to 1.5 is mild positive lupus anticoagulant, 1.5 to 2 moderate, and more than 2 is a marked positive. How do you interpret for LS screen and LA confirm? If all are normal with patient, then lupus anticoagulant is not detected. If LS screen is abnormal, mixing is abnormal, but confirm is normal, then LA is present. LS screen is abnormal, but mixing becomes normal. Confirm is abnormal, mixing becomes normal, then this is indicates your factor deficiency. If LA screen is abnormal, mixing abnormal, confirm abnormal, and but confirm mix is normal, then you might be dealing with an LA plus factor deficiency. If all are abnormal, you might be dealing with another inhibitors. Coming to sixth case, 15-year boy referred to for IC bleed. Is a known case of hemophilia A. As usual, you have done an APTT is prolonged. Factor rate is less than 1%. What next? So as I have told, mixing study. So mixing study with half patient and half control, that is PNP. And how this mixing study actually works is that the PNP has nearly 100% of each factor. If you do a half of control, that means 50% of all factor you are mixing. Even if your factor levels in the patient's plasma is 0, it achieves a 50% factor level. And once it achieves a 50% factor level in any mixture, it will produce almost near normal PT or normal PT and APT result. So in presence of inhibitor, what will happen? The inhibitor will not allow this added coagulation factor coming from the pooled plasma to act. So your correction studies will not show any correction. So absence of correction indicates inhibitor. Even in a hemophilia A case, the inhibitor might be because of a factor VIII inhibitor or factor VIII antibodies. So these factor VIII antibodies, you have to remember that time and temperature dependent inhibitor. So when you do a mixing study or do a inhibitor screening, you have to do some change or modifications where you have to look for an immediate mix and incubated mix. Incubation, you are allowing the inhibitors to act on, and with incubated mix, if the factor VIII inhibitors are there, the incubated mixture will show prolongation of the APTT result. So how do you then interpret? A difference between immediate mix and incubated mix of more than 10 seconds is considered positive. So let us see into 3 scenarios where normal plasma and test plasma, both the incubated and the test plasma, both are showing correction. So it is an intrinsic defect. If the test where incubated mix is higher than the fresh mix, and more than 10 seconds shows a time dependent inhibitor. If both are higher, then it is an immediate acting inhibitor. A high level of factor VIII inhibitor can also show immediate acting inhibitions of the APTT result. Who should undergo inhibitor test? A severe hemophilia A or B with every 3rd exposure day or every 3 months until 20th exposure day. After 20th exposure day, they can every 3 to 6 months up to 150 exposure days. And hemophilia A 1 to 2 times after that yearly, they should undergo inhibitor testing. Hemophilia B, testing after 150 exposure day. Mild moderate can undergo yearly or whenever there is a mutation with a high inhibitor prevalence or a family history of the inhibitor are there. So next you have to do an inhibitor assay. There are 2 methods of doing inhibitor assay. One is a Bethesda assay and Nijmegen's assay. Nijmegen's assay is a more sensitive assay because you are using a factor VIII deficient plasma. So the inhibitor assay is based upon the principle that one Bethesda unit will reduce the factor VIII levels to 50%. So you have to do serial dilutions of the inhibitors, because by doing a serial dilution, you're reducing the inhibitor level and trying to achieve a 1 Bethesda unit in one particular dilution. Whichever the dilution will achieve nearby 50% of the residual factor VIII activity, you have to multiply that Bethesda unit with the multiplication of the dilution factor to get how much inhibitors are there in your sample. So coming to our case, we have done an inhibitor assay. We got a 6.8 Bethesda unit. Depending upon the inhibitors level, they can be high responding and low responding. If there is a less than 5 Bethesda unit of inhibitors are there, and accordingly the management differs. So coming to the next case, 60-year-old male with total knee replacement done 4 days back in outside hospital, bleeding from the surgery side. Exploration has been done. There is a generalized whose hemostasis is achieved. CT angiogram shows no aneurysm. Bled twice again and requiring a re-exploration. PTA and APTT was prolonged. Factor assay was sent to the outside laboratory to New Delhi from Odisha. Factor VIII levels are 35.99 are 9.1. So factor VIII was infused, but there was no response. But surprisingly, there was no action was been taken for factor 9 deficiency or low factor 9. Repeat factor assay that has been performed in our center shows that factor VIII was 130 and 9 was 22.4. So what you will learn lesson is that off-site coagulation testing can be tricky. On-site testing is safer. Coagulation factors are highly sensitive to temperature and storage condition. If anybody asks me if I want to, you want any sample of coagulation to be outsourced, it's better to not to outsource the sample, but outsource the patient. So send the patient to the off-site lab directly so that at least the results will be correct. Coming to the next case is a 45-year-old male with excessive bleeding following tooth extraction. Young dentists get panic, possibility of mild hemophilia, coagulation workup suggested. Sample sent for factor VIII assay. Your test looks normal. 8 is 13.2 on the same sample. Diagnosis of very mild hemophilia, but surprisingly bleeding stopped with local measures. No factor FAP or GAR given. On follow-up, PT and APTT were normal and 8 levels were 89.5%. Possibly what happened is that when we inquired, the first sample tube had a small clot that has been thrown out. So what you learn, a bad sample can mislead badly. Pay attention to pre-analytical variables, and a stepwise approach would have avoided an erroneous conclusion. Coming to the next case is a 3-year-old boy with cyanotic heart disease of hemoglobin 21.3, Paxil volume 70.5. PT and APTT both shows prolongation. FAP has been transfused in view of the blood thin's expectoration. Lab hematologist was called for another sample in the citrate adjusted tube. So what is important? Citrate adjusted tube in view of CBC. Citrate adjusted tube, the PT and APTT shows a normal value. FAP transfusion actually was not required. Hemoptysis could be due to pulmonary congestion. So let us understand our case and between both. What happens is that you are doing using sodium citrate. You are actually citrating the plasma. In case of a high hematocrit, the level of the plasma is low because RBCs are high. The Paxils are high, levels are high. Because the plasma is low, the amount of the anticoagulant is high, and citrate is a calcium chelator. And during a testing of PT and APTT, what you actually do, you do a recalcification. So requirement of recalcification in a citrated plasma from a patient with a polycythemia is more. So what is a solution? Solution is correction of the anemia is not required, for correction of the polycythemia is required. So how do you correct? Whenever the hematocrit is more than 55%, suppose you are using a 3 ml vial, the multiplication factor, the amount of the blood that need to be added to it is 60 into 2.7 divided by 100 minus patient PCB. Similarly, if you are using a 2 ml vial, it is 60 into 1.8 divided by 100 minus patient PCB. That amount of the blood, you open the cap and add that amount of the blood. So lesson learned, be aware of the coagulation result in patient with very high hematocrit. Pay attention to pre-analytical variable. 40-year-old male with acid tromp or DBT admitted with fever since 3 days. PT is 75, INR is 6.42. Call for the physician, call from the physician. Previous INR to 1 week back was 2.25, so no change in drug doses. Lab was allotted, find out about the venipuncture. Repeat sample was taken, repeat testing was done, and the repeat testing shows the INR to be 2.17. Had it been the repeat testing has not been done, it would have been like that. The patient might require a lot of FFT because 6 is the critical value. So what you will learn, coagulation result out of proportion to clinical expectation must be repeated. Repeating a test is in coagulation is not a crime, and it can be an artifact. So there are papers which shows that how to interpret and pursue an abnormal PT, and what is shows that before embarking on a complex investigation of a prolonged PT and APTT, clinicians should consider repeating the testing to exclude artifactual results. Coming to the next case, 50-year-old male with resolving pneumonia, hemoglobin 9.6, TLC 18,500, platelet 2,50,000, PT is normal, APTT high, repeat sample shows PT borderline high and APTT is again high. Actually, the sample APTT is normal. Actually, the sample has been taken from a central line. So what you have learned is that samples from critical care areas, there is a chance that it could be contaminated with heparin. Repeat testing should be done from another sample collected from a peripheral line. If somebody is collecting from the central line, one has to discard 10 ml of the blood before collecting for coagulation testing. So this is the summary of differential effect of testing different sample on select hemostasis test. So whenever there is a partially filled or partially clotted or underfilling samples are there, you can see the results will be erroneous. Heparin contamination can also lead to erroneous result. Similarly, inappropriate sample processing can also result in an erroneous hemostatic result. Coming to the next case, 7-year-old girl with ecchymotic patches over abdomen on and off since 2 years of age, also bleed longer than usual with trauma, has had gum bleed as well. Testing done shows platelet hemoglobin TLC platelet almost normal. Bleeding time is normal. PT, APTT, everything is normal. So declared the lab to have no bleeding disorder, but clinician insisted. So urea solubility testing has been done. So you can see after 24-hour incubation, the patient's sample shows soluble clot. So there is no clot in the patient sample. So there is no fibrin factor 13 in patient. So factor 13 screening is positive. So further probing or further looking into has a history of delayed wound healing. So what you have learned is that history will always point to a diagnosis, and you have to look beyond the normal pathway, that is PT and APTT alone. Whenever they are normal, please think of urea solubility test or factor 13 deficiency or platelet dysfunction. 9-year male child presented with repeated episodes of epistaxis, aggravation of the symptom following a fever with antipyretic, no organomegaly, evaluated outside to have a 48,000 platelet count. Bone marrow aspiration has been done. It shows a megakaryocytic hyperplasia. What is your diagnosis? So we have an isolated thrombocytopenia, but the onset is chronic. There is no signs of organomegaly, no drug history, and no only previous infection is there. With this typical history, it is prudent that you will think of ITP. But revisiting the history, we could elicit that there is easy bruisability and gum bleeding from the trivial trauma from an early age, and he was born of second-degree consanguineous marriage, with father having history of epistaxis during childhood, which stops spontaneously, and he was not evaluated. Possibly we are dealing with an inherited platelet functional disorder. Just to highlight this cartoon to show you, the platelet adhesion happens by interaction between von factor, collagen, and glycoprotein 1b receptor on platelet. So whenever glycoprotein 1b is defective, we say that this person might have Bernard-Solier syndrome, or a von factor deficiency also lead to bleeding manifestation. Then followed by adhesion, that platelet would undergo aggregation. Aggregation happens between two platelet, and the receptor for it is glycoprotein 2b3a, and the bridging molecule is fibrinogen. A 2b3a complex is deficient, can indicate Langerhans thrombasthenia. So how do you then use platelet aggregation studies? A basic rule, if aggregation is seen to all the agonists like ADP, collagen, histiocysteine, arachidonic acid, but adrenaline, if aggregation is there, then you are dealing with no platelet functional disorder except for your secretory defects. If there is an abnormality only to restore, your diagnosis differential are 2, von Willebrand or BSS. If there is absent aggregation to all except restore, then it could be dealing with the Glanzmann's. As you can say, restore can be a mimicker of your von Willebrand factor activity in your platelet aggregation, in your platelet activation process. So, looking at our case, you can see there is aggregation to all agonists like ADP, epinephrine, collagen, arachidonic acid, but there is absent aggregation to restore. Mean platelet volume was 18 femtoliter. So we have two differential BSS versus von Willebrand. So we did a mixing with cryoprecipitate. Cryoprecipitate is rich in von Willebrand factor. With mixing also it didn't correct. So our diagnosis is Bernard-Solier syndrome. So what you have learned, history is crucial. Platelet functional disorders should be considered in case of unexplained inherited mucocutaneous bleeding. So coming to just I am skipping just a note on bleeding and clotting time. These are very favorite pre-op screening tests. Their real clinical utility is negligible. Awareness should be there that there is a changing trend and is a limited use. Still, people are using it. But what we have done in our place is that we are not anymore using clotting time, bleeding time only after consultation with the clinician. So clotting time is an obsolete test, and bleeding time in case to case, if you are doing, you have to do in a very standardized way. Coming to the last case is a 54-year male, chronic alcoholic, increasing abdominal distension for 2 months, no fever, chill, abdominal pain, hematemesis or spontaneous bleeding, vitals are stable, laboratory workup shows a PT-INR of 2.8. Is the patient has a bleeding risk? Can patient undergo liver biopsy? So what do we believe that a raised prothrombin time seen in liver disease commonly expressed as INR reflects a bleeding risk and need to be corrected with the plasma products. Platelet transfusion is required if thrombocytopenia is there to do a liver biopsy. But studies have shown only 33.9% have coagulopathy, and major bleeding after an invasive procedure in a liver disease happens only in 2.4%. So what usually happens is that in liver diseases, both the procoagulant and anticoagulant factors are reduced proportionately. So the balance, the hemostatic balance is being maintained. And they are reduced in number, and this balance is quite unstable, as you can see from the cartoon. And whenever there is a renal failure or infection, it can cause more of bleeding manifestations, altered blood flow or endothelial, it can cause thrombosis. So this balance is quite unstable. So there can be a bleeding or thrombosis in either way. So abnormality in hemostasis testing may not bleed or thrombose always. The example is rebalanced hemostasis is observed in liver disease, and hemostatic balance is relatively unstable. Prophylactic correction of hemostatic abnormality or platelet count is not evidence-based in liver disease unless until they are therapeutically you can give whenever there is a bleeding or thrombotic event. Hope I have cleared some of your conundrum. Now you feel better relaxed and more clear about the coagulation. Thank you.
I have taken my presentation on the acute leukemia flow cytometry. So I'm taking it like right from the base, like right from the bottom, just trying to make you understand the flow cytometry, how you look at the samples, how you put a gate, what is the forward scatter, side scatter on, small things like that. So I hope I'm not going to be wasting your time. So without wasting any time, let's start. I just want to confirm once again that can you see my presentation?
Yes. Yes.
Okay. All right. Thank you, Dr. Rajesh. Okay. So now let's have a look at this. This is a blood picture from the normal peripheral smear. So what we normally see is we see a neutrophil, we see a eosinophil, we see a lymphocyte, we see monocytes, and we see basophils. So when you look at the peripheral smear, you can actually identify each of these cells because you are seeing the morphology of these cells. But when we look at the flow cytometry, how do we look at the flow cytometry? We look at the dots. We just have the dots in front of us. So, you know, this is a dot, this is a dot, this is a dot. I don't know what it is actually, but everything is based on the position of these dots. So with our experience, I know that these are the neutrophils. This population is the lymphocyte population. This is the monocyte population. But how? So let's understand one thing, that flow cytometry basically analyzes various properties of the cell. So it analyzes the physical properties and it analyzes the chemical properties. Now, when we talk about the physical aspect of a cell, we are talking about two parameters. One, of course, is the side scatter and one is a forward scatter. So the side scatter basically talks about the complexity or the granularity of the cell. The forward scatter, on the other hand, tells us about the size of the cell, right? So now what happens is that this population that you see, which is on the extreme left and bottom, clearly shows that this is a small size population and also shows us that this is a very less complex population. And this population actually is your lymphoid population. Sorry. This is your lymphoid population. Then this population, which is on the extreme right and is obviously larger in size, is actually your neutrophilic population. So what we have to understand is that the higher side scatter, higher forward scatter will give you a neutrophilic population. The smaller ones will be the monocytic population, and somewhere, sorry, this is the lymphocytic population, and somewhere in between will be your monocytic population. So what we can do is we can actually put gates around them. So this thing is called gating. So we can put a gate around it. We can call it, give it a specific color so that you can actually, for further analysis, use that color. So what we have done is based on the forward scatter and the side scatter. So that is the physical property of the cell. We're dividing the cells into three populations. One is the lymphocyte, one is the monocyte, one is the granulocyte. All right. Now, when I look at this lymphocytic population, do I know whether these cells are T cells or they are B cells? No. Do I know whether they are normal or they are abnormal? No idea. So basically the physical property of the cell will just tell us whether it's lying in the lymphoid region, monocytic region or the granulocytic region, but it will not tell us anything more about it. Here comes the value of the chemical properties of the cell. So when we talk about the chemical property of the cell, we are talking about the antigenic expression of the cell. All right. So when I say antigenic expression of the cell, I am talking about the fluorescence of the cells, okay, because we are using antibodies. Now, so before I go on to the chemical properties of the cell, I will actually just like to emphasize again on the parameters of the flow cytometer. So the following are the parameters: the forward scatter, the side scatter, and the fluorescence. So for example, if you have a 6-color flow cytometer, a 6-color flow cytometer will have 6 colors in the fluorescence, and additionally we'll have these two parameters. So in total we will have about 8 parameters. So a 6-color flow cytometer will have 8 parameters. A 8-color flow cytometer will have 10 parameters. A 12-color flow cytometer will have 14 parameters. All right. Now let's go on to the most important. So now when we're talking about the chemical properties, do you know which is the most important marker in the flow cytometry? Can anybody answer that?
I'm CD34.
Yes. No, not sorry. CD, not CD34. Anybody else? Anybody else on this? Okay, so the most important marker actually in flow cytometry is CD45. Okay, CD45 gives you a very, very, very clear picture of what is happening in the peripheral blood. So now let's have a look at this. All right. Now, this was the picture that we had already seen. There was a forward scatter and there was a side scatter. Now you had a lymphoid population, monocytic population, granulocytic population. So if I just give it a black background, because I like the black backgrounds more than the white backgrounds. So again, this is the lymphoid population, this is the granulocytic population, this is the monocytic population. Now, when I look at the same population, when I use a CD45, so see how it looks like. The y-axis is the side scatter and the x-axis is actually the CD45. Now, can somebody tell me that how many clusters do you see on CD45? When you have a size scatter 45, this is one thing that you see. Can anybody tell me what is this?
Grants.
Very good, perfect. What about this population?
Lymphocyte.
Perfect. So always remember that the population which is on the extreme right, that means which is the brightest. So first of all, let me ask you a question. Do you understand when you're on x-axis, the population which is on the right hand side is actually the population which is brighter, the population which is in the middle is kind of dim, and the population which is on the left hand side is negative. All right. So this population, which is the CD45 population, is actually the brightest population, and it is a lymphoid population. So always remember the brightest population on 45, whatever you see, is the lymphoid population. Can somebody tell me about this?
Monocytes.
Monocyte.
Perfect. So we have the lymphoid, monocytes, and the neutrophils. Now the same picture, when you see the forward scatter and the side scatter, you see lymphoid cells, monocytes, and the granulocytes, right? The same three division, but here the division is based on the side scatter in 45. So please visualize this graph. This graph is actually one of the most important graphs that you would be needing to further evaluate what things are. All right. Now I will go to another thing. I've just colored them differently because you can put a gate around them and give them a different color. So colors actually give you a better idea. Now let us again look at this. Now this, why did I say that 45 is the most important marker? Because there is something which is called this area, which is called the blast hole or called the progenitor gate. This area actually has all your immature cells. All right. Now this is a bright 45. So this area would be dim 45. All right. Now this dim 45 area has all your normal progenitor cells also and have your abnormal cells also. All right. So this population. So this is a very, very important area. So can anybody tell me that this area, is it empty in a normal patient, or does it have something? Would anybody like to answer, or should I actually give an answer?
It will
Yes or
have
no?
because normal cells, immature cells will be present in
Immature
even
cells
normal patient.
in a normal patient. So okay, so let me put it in another way, that in the peripheral blood, do you have any immature population which you will find in this gate?
No.
No. All right. So peripheral blood has all the mature elements in a normal patient. So you don't expect anything in the progenitor gate in the peripheral blood. Now in the bone marrow, all right, you will probably find some immature cells. So can somebody tell me what are the immature cells which are present on the dim 45 region in the bone marrow of a normal person?
Hematogones.
Very good. Anything else? They are normal. Okay, so I will give you a list of cells which are present in the dim 45 region in a bone marrow of a normal patient. All right. Now let us look at this. So you have the normal myeloid blast, because you know there are myeloid blasts which give rise to the mature neutrophils eventually. They are present in the normal marrow. Hematogones, which are the precursor B cells. Okay, they give origin to the B lymphocytes eventually. So they are present. The basophils, the dendritic cells, and the plasma cells. Though these three populations, they are not immature, but still they are present in the dim 45 region. So one has to be very careful to call something abnormal. But first you have to rule out these normal cells, then you have to say there is something which is abnormal present. But remember that these cells that are present in small quantities. They are not present in huge quantities. All right. Now have a look at this one. This is the side scatter, and this is the CD45 of a patient having a normal bone marrow. All right. So can somebody tell me what is this population?
Lymphocytes.
Perfect. What about this population?
Sites. Granulocytes.
Granulocytes. All right. Now let me
Lymphocytes.
show you this area, which I told you was very important, because this is actually your progenitor gate, right? Now this is the position where the yellow colored cells are your normal myeloid blast. This is the position of the normal myeloid blast, and they are usually less than 5% in a patient, in a normal person. All right. So I want to show you the positions of these normal cells before we go on to the abnormal one. So this is the position of the normal myeloid blast. Now let's have a look at this case. Now this is again the extreme right population on the CD45, which we will call as lymphocytes. This population is the granulocytic population. Now again we put the same gate here. What do we see? Now there is something which I will highlight in this picture here, which is coming out of the progenitor gate, but it is DIM45 region. And can somebody tell me what are these?
Ma'am, they can be normal or abnormal blast. Abnormal.
Perfect. So normal or abnormal blast, all right. Okay, anybody else? Okay, so your answer is right. They can be normal, they can be abnormal. But when you look at this, okay, so why have I put these is because just see one thing, that they have a very low side scatter, like they are extremely at the bottom, and you can see 3 clusters, 1, 2, and 3. So when you see these 3 clusters together, okay, like it's like one cluster holding the hand of the other one, holding the hand of the other one. This is how the normal hematogones, they look like. So when you see this, just know that they would be hematogones, all right? So this population is the stage 1 hematogones, this is the stage 2 hematogones, and these are merging with the lymphocytes. So these are the mature B lymphocytes, all right? So always remember the look of this on the side scatter 45 is like this, like 3 tiny populations holding each other's hand, and they are the hematogone population. So if I have to put the two populations together, this population which is pink is your myeloid blast, which is the normal population, and these 3 clusters are your hematogones. So this is the position of the hematogones. So you should not call these abnormal. When you see this kind of a thing, you should know that these are normal hematogones. All right. Other populations which I told you also present in this region are, you have basophils, which are present somewhere a little bit on the right hand side of the myeloid blast. These are called the basophils. Okay, so I put the myeloid blast here. These are the basophils, and here you have the hematogones. Now this population is your blast population, which is the myeloid blast. This population is the plasma cells. So always remember, plasma cells are also DIM45, but they are again in this hole. And the dendritic cells are also somewhere present here. So remember that there are 5 normal populations which are present in the DIM45 region in a normal person. They are the myeloid blast, they are the hematogones here, the plasma cells here, the basophils here, and the dendritic cells here. Am I clear with this? Then we will go ahead and we will try and identify how we find how can we differentiate the normal from the abnormal ones. But before we call anything abnormal, we should know that these 5 set of cells are present in the marrow of a normal person. All right. But they are present in small quantities. They're not present in huge quantities. Now, do you have any questions still here, or can I progress to acute leukemia? I think I'll take it as going further. All right. Now, how do we approach a case of acute leukemia? So what do we do is that we take a sample. Say there's a patient who comes to you. He's a suspected case of acute leukemia. So you will just take the peripheral blood of that patient. And now what you have to do is you have to add all the antibodies to it. Now let us forget about all the antibodies. Let us talk about only CD45 till now that we have discussed. So we will put CD45 antibody in this blood sample and we will keep it for some time, and then we will run it on the flow cytometer. Now the first step of gating is you want to identify the blast. All right, you have to identify the blast. And how do we analyze how do we identify the blast? The most important, again, fluorochrome is CD45. So what we do is that I have put on the left hand side, this is the normal blood picture. So what have I done is, on the right hand side, this was the progenitor gate that we had discussed. All right. So when you look at this picture compared to this picture, can anybody tell me what is the difference between these 2 pictures? Or I'll keep asking you one by one. So what is this population that you see here? Can anybody say what is this population?
Lymphocyte.
Yes, perfectly. This is the lymphoid population, right? Now, if you compare this picture, this is also a peripheral blood picture and this is also a peripheral blood picture. All right. Now, when you compare this picture with this picture, clearly we see that the granulocytic population that should have been there is not there here. Am I right?
Yes,
That's
ma'am.
one thing.
Yes.
The lymphoid population is a very tiny population, and in this red progenitor gate that I have marked, there is a huge population which is dimmer 45. All right. Now, obviously, this is not lying exactly in this circular gate, so we will change the gate. Okay, how do we change the gate? Is we actually put a gate around the population which is abnormal clearly, because this is dimmer 45, which is not expected to be present in the peripheral blood anyways, but it is there. So you put a gate around it. All right. Now, this population is most likely your abnormal population. Why? Because it is huge in size. You don't expect that in the peripheral blood. It is in the dimmer 45 region. All right. This is how you gate the blasts. I will show you some more examples of how you gate the blast. So now when you see something which is dimmer 45 in huge numbers where you don't expect it, and when the other populations have actually kind of considerably gone down, then you should think that these are abnormal cells. What abnormal cells, we don't know as of now. We can just say that these are abnormal cells. All right. Now have a look at the other example. So again, for your help, on the left hand side, we have something which is like a normal one. On the right hand side, there is something which is abnormal. So can anybody tell me, again, we put the gate that we want to put, but can anybody tell me, does this look normal or this doesn't look normal?
Ma'am, it's
Not
abnormal.
Abnormal, clearly abnormal. So you have a
Oh,
lymphoid population here. So always remember that there is a tiny population of lymphoid, even in the largely abnormal samples. You know, you always have that tiny 1 or 2% of lymphoid cells which will be there, which will help you understand that this is a dimmer population which is present, because this is the normal population, and therefore this is the dimmer population which is clearly there, and there's a small gap that you always see. There may be a gap, there may not be a gap, you know, but usually you see a gap, and that's what tells you that this is abnormal. So we will put a gate around this, and we will call this as abnormal population. All right. These are some granulocytes which are still there. Again, I'll give you a third example. Here, what all can you see? Does anybody want to take this and tell me what it is? This one is. Does this graph does it have any abnormal cells here or no? So, okay, I'll do it.
yes,
So
it
this
does.
population, okay, you want to go ahead? Please go ahead. No? Okay. So this population,
Lymphocytes have increased.
okay, lymphocytes have increased. So do you see here something which is on the extreme right? This is the lymphoid population, but there is some tiny gap here, and you see another cluster here. Do you see them as one, or do you see them as two?
2.
Two clusters, all right. So normally, if this was a lymphoid, see on the right hand, left hand side, you clearly have one population. Here, you clearly have two populations which are very close to each other, but you cannot say that they are the same population, right? Because this is clearly a dimmer 45. This is clearly the brighter normal lymphoid population. So what we will do is, this was a progenitor gate. We will remove this gate and we will put another gate, and we will call this population as abnormal. So what happens is, when you're doing flow cytometry, you have to actually gate a population and then try and find out whether that population is normal or that population is abnormal. All right. So this is how you actually do the gating bit. So here we feel that this is the normal population. All right. Though of course nothing will go on our feelings, you can gate this population also, and depending on the further markers, you will find out whether this is abnormal or normal. But this is a suspicious population clearly, which shows that yes. So you know, in these kind of things, when you see the peripheral smear, you will see that there are maybe 30% neutrophils, there are 30% lymphocytes, you have some debris, and then you see about 30% cells which don't look normal, and this is where they will lie clearly. I'll give you another example. Now this one. This is clearly the brighter 45 lymphocytes. This is your granulocytic population. Now here we see one population which is a little, if you look at your blast, if you look at your progenitor gate, this is actually not even in the dimmer 45 region, but it has gone to even dimmer 45 to negative 45. So this is actually your population of interest here. that this is your suspicious population, and you would want to find out that what is this population which is so dim 45 or it's even negative for 45. All right. So now your gate will be on this population. Now have a look at this one. Again, clearly you see there is a clear lymphoid population. What we see here is you have a gate around the progenitor gate. So there are cells which are lying in the dimmer 45 region, but clearly it's much bigger than that. So we will increase the size of our gate to include all the cells. See, because this is together, this is like one big cluster. It's not two separate clusters, all right? So that's why we are trying to increase the size of our gate. Similarly, when we see this here, now this is a lymphoid population here. So this time your progenitor gate is actually here, all right? The cells are not in the dimmer 45 region, but clearly you see that this does not look normal, all right? Because your granular size should have been here. Your lymphocytes are here. Maybe this is a monocytic population, but this is like a huge monocytic population. So if you look at the percentage, it seems like it is more than 80% of all the cells, right? So you consider this as a suspicious population. So as of now, we would not say that they are abnormal or they are normal, but we will just say that this is a suspicious population. So we would want to put a gate around it, and then we would want to see what it is. All right. Again, like, have a look at this one. Now, this is the lymphoid population. Can somebody comment about this one?
High side scatter.
High side scatter with these cells. So do you think that they can be the neutrophils?
No, they aren't.
They are not the neutrophils. Why would you say they're not neutrophils? See, like this is
Because
the
the
population.
centroid is
Okay,
downward.
very good. Okay, so it's very interesting, the word centroid that you have said, that it seems like a teardrop, which is like really sort of pulling it down. The center of this
Yes.
entire population looks much lower compared to this one where you see a very high side scatter. All right. So again, I would at this point not call it abnormal. So again, the center has come down. It is actually more of the cells are here than actually here. So I will put this entire population as a suspicious population. Okay. So now we will actually go further in every case and see what these cells are. All right. So till now, this is the first step, which we call as the gating, where we do the side scatter 45 gating to identify which is a suspicious population. Am I clear till here? So I have covered two things till now. The first thing that I have told you is that there is a population of cells which is present in the dimmer 45, which is normal, which are the normal myeloid blasts. They are the hematogones, the basophils, the PDCs, and the plasma cells. And the second thing I have told you is how to put a gate using the side scatter 45 in acute leukemias. All right. Now, once we have a suspicious population, the next step is we also want to find out that whether this suspicious population is blast, and if they are blast, then what are the markers present on them? All right. So can you tell me one before we go ahead? Is there any population which is okay? No, forget that question. Sorry. Okay, now I'll go to the step 2. Now we have to find out what are the blasts. So can you tell me the different type of the blast which can be present?
Myeloblast and lymphoblast and
Myeloid
monoblast.
blast, lymphoid blast.
Perfect. Okay, so you have myeloblast and then you have the lymphoid blast. In the lymphoid, you basically have the B and the T blast. All right. Now these are the three most important categories, which is like you have to identify basically as the blast as B or as a T or as a myeloid. The three most important. Can you see it on morphology?
Yes, ma'am.
You can see on morphology. So
We
can you
can
tell me?
predict.
You can predict, okay, but you can never be sure.
Sure.
But definitely between the lymphoid blast and myeloid
Sure,
blast, we've
yeah.
all been taught that the myeloid blasts are larger, they have a nucleoli. And if you see a aurora, definitely it is a myeloid blast, right? But can you differentiate between the B blast and the T blast?
Uh, T are more like hand mirror, and B have got like
Not
a
very
cleaving
surely,
involved.
but we can predict.
Yes, exactly. So very right. So when you see a hand mirror appearance, you think it's a T blast. If it's a smaller blast, then you will say it's a B blast. Then you will say it's a L1 blast, it's a L2 blast, or maybe it's a
And
Burkitt.
then
And,
cleaving also.
cleaving also. Absolutely. So, there are some features which suggest that they are B, T, or they are myeloid. But a lot of times, if you start doing flow and you start correlating, then you realize that how many times you're wrong. All right. But it's
True.
actually a good exercise. Once you start doing flow cytometry, you should actually do a morphological analysis, and then you do a flow cytometric analysis, and then you actually correlate. All right. That were you right morphologically or not? Because eventually, objectiveness is what it is important, right? You have to treat the patient. So now, how do we identify the B blast? Or obviously, if there are no markers present, then they are undifferentiated blast, or it could also be a mixed phenotype blast. You know what is a mixed phenotype blast? A blast which actually can express a B
Yes.
and a T, or a myeloid. A myeloid, it's a mix of B and T and myeloid. All right, it could be anything. So now we are actually now, so this is clear. So it could be B, T, myeloid, but the slide will never tell you whether it's an undifferentiated or a mixed phenotypic blast. Only a flow cytometry can tell you whether it is undifferentiated or a mixed phenotypic blast. All right. Now, can somebody tell me the important markers? Now, I'm going to be discussing very few markers which are superficial, which will help you understand. Like there can be huge number of markers, and there are like increasing number of markers every time. But now let's talk about the B blast first, okay? The B lymphoid blast. So can somebody tell me the important markers which help us identify the B blast?
CD19, CD10,
Very
CD20.
perfect. Okay, so CD19, CD10, CD20, and cytoplasmic CD979A. Out of these markers, which is the most important marker?
Ma'am, CD10.
No,
Oh, sorry, ma'am. It's CD20.
19.
no. Okay, so
Ma'am,
19 and 79A, I would say. Okay, now always remember the 79A that we are talking about is a cytoplasmic marker. So when you have a cytoplasmic marker which is positive, it's actually very specific for that lineage. So if you have a cytoplasmic 79A which is present in the B blast, you know that it is a B blast. It may be 10 negative, it may be 20 negative, because remember, most of the acute leukemias are 20 negative. All right. So, and most of the B cell leukemias are 10 positive, but they may be 10 negative. So CD79A becomes a very important marker in determining the lineage of the marker. And CD19 is a pan B cell marker. So can anybody tell me, when I say CD19 is a pan B cell marker, what are the B cells on which CD19 is positive? So
Plasma cells.
plasma cells, perfect. So plasma cells have a CD19. Then what else? Okay, so I'll tell you. So you have hematogones which start from stage 1. All right. So you have stage 1, you have all hematogones which are 19 positive. You have all the mature B lymphocytes which are 19 positive. You have all the plasma cells which are 19 positive. Remember, so CD19 is a very important plasma, it's an important pan B cell marker. Remember that CD20 is actually comes in the middle. Like it's not present on the stage 1 hematogones, it is not present on the plasma cells, but it is present on the mature lymphocytes. So 20 comes in the middle, but CD19 is truly a pan B cell marker which actually has all the B cells covered on it. All right, so just understand the B cell markers, the 19 and CD79A are the most important. 10 and 20 are also very relevant. All right, now let's go to the T blast. Now, can somebody tell me which is the most
CD3,
important? Perfect. All right. Perfect. So
CD7,
remember that. Okay, 7. What else?
and 2, 3, 4, 5.
Perfect. All right. So 4 and 8. So let's say out of all these markers again, what is the most important one?
CD3.
Yes. Okay. CD3 and CD7 are very important. Remember that CD3 again is very important, but it should be present in the cytoplasm. So if it is present in the cytoplasm, then surely we know that it is a T blast. So when we are talking about markers here, we can actually have the expression on the marker on the surface. We can have it inside the cytoplasm. So normally what we do is in flow cytometry, we check out the surface markers and also few cytoplasmic markers. And in the few cytoplasmic markers, one marker that we use is this cytoplasmic CD79A, because it is important to determine the lineage. So lineage will be determined very specifically by the cytoplasmic markers. And thus also we use a CD3. So we use a surface CD3 also, and we use a cytoplasmic CD3 also. All right. So in T blast, your cytoplasmic CD3 has to be positive. Then the third category is the myeloid blast. Can anybody tell me about the myeloid markers?
13, 33.
Yeah. Perfect. So 13, 33 are very important markers, but they are not so
MPO.
specific. Remember, yeah. So cytoplasmic MPO, if it is present, then you know for sure it's a myeloid blast. All right. 13, 33 again are usually present on the myeloid blast. 64 and 14 are monocytic markers, and CD117 is also a myeloid marker. So we will discuss about these markers separately, but understand one thing, that if you have a cytoplasmic CD3, it's a T blast. If you have a cytoplasmic 79A, it's a B blast. If you have a cytoplasmic MPO, it's a myeloid blast, but a lot of myeloid blasts may not have a cytoplasmic MPO. Doesn't mean that it is not a myeloid blast. All right. And the rest of the categories is will follow. Now, what we will do is that we will make a panel. Okay. Now, say for example, you have a 8-color flow cytometer with you. Now, what we have done is that I hope that I'm not confusing you by putting out these tubes like tube 1, tube 2, tube 3. So what we do is, say, for example, you have a flow cytometer, you have the blood of the patient. Now you will take 3 tubes. In the 3 tubes, you will put the blood of the patient in the first one, in the second one, in the third one. Now, what is one marker that should be present in all the tubes that you need for gating?
45.
Yes, very right. So you have to put a 45 because that will tell you the abnormal cells that you are wanting to study. Okay. So 45 should be put in all the tubes. Then obviously, what are the other markers that you have to put? You have to put some B cell markers, you have to put some T cell markers, and you have to put some myeloid markers, right? Based on that, you will actually get to know what is the lineage. So I don't want to confuse with this entire tube, but what we have done is understand CD45 is on all the 3 tubes. CD34, can anybody tell me what is CD34?
It's
Yes,
common
it's
blast.
basically it's a immature cell
Blast.
marker. It identifies the blast. Okay, so a CD34 positivity surely means it's a blast cell. There is no other cell in the marrow which is actually CD34 positive, which is not a blast. All right, so 34 clearly shows it's a blast cell population. So we're putting the 34 also in all the tubes. It may not be necessary to put it, but if you want, you can put it. Otherwise, we are putting the, like in the first tube, we are putting the B cell markers. In the first tube, most importantly, there is the 19. In the second tube, there is a very important cytoplasmic CD3. And in the third tube, we basically have the myeloid markers like 13 and 33. We have a combination, so we will not go into the details of how to make a panel that we can discuss in some little advanced sessions. But understandingly, importantly, that you have to put all the lineage markers, all right, in the tubes. Now, let's have a look at the case, and then we will try and understand it. This is a 5-year-old boy who had pancytopenia, okay, and they had done a bone marrow. Now, this was the sample that we received. So can anybody tell me which is the abnormal suspicious population in this one?
Extreme left.
Extreme left. Perfect, okay. So this population comprises of 65% of the cells. Now, this should be the lymphoid population. This should be the granulocytic population. Now, when I talk about this population, which is the extreme left, which is the DIM45, this is a suspicious population. Now, I will forget about the green cells. I will just concentrate on the yellow cells. And I will keep showing you the markers which are positive for it and negative for it. So can you see the 34? Is the 34 positive or negative?
Positive.
Very right. So that means clearly that they are blast, right?
Yes, ma'am.
Okay. What about the 19? This is the
Ma'am,
CD19.
that is also positive.
Perfect. So now we know that they are 19 positive, they are 34 positive. So we are going towards what diagnosis?
ALL.
Very good. BLL. So what are the other markers you would want to see on it? You would want to see a CD10. So what is the CD10?
Ma'am, positive.
Perfect. Positive. Can somebody tell me what is this green population?
Ma'am, this is a myeloid
Mature B
population.
cells.
Mature B cells. Very right. So when we go back to this population, there is a small population of lymphoid cells also here. So if we had this green population, there would be a population amongst those cells which are 20 positive, which are B cells. And what is this population out of the green population?
T cell population.
T cell. Very right. So the 20 negative would be T cells and the 20 positive would be B cells. And this would be your blast population. All right. Now let's have a look at the CD13 and 33. What is it?
This is positive.
Negative.
This is negative, right?
Oh,
So
sorry,
yeah,
ma'am.
so
Yes.
No problem, no problem. All right, so this is negative. So the 13 is negative, 33 is also negative. When we look at the cytoplasmic CD3, so what have I done is I'm showing you the B cell markers first, then I'm showing you the myeloid markers, and then I'm showing you the T cell markers. So again, the cytoplasmic CD3 is negative and 7 is negative. So what is your diagnosis?
B cell ALL.
Okay, so clearly B
Kala
cell ALL.
positive.
Yeah, so Kala positive B cell ALL. So we have basically clearly seen the gating first and then the markers. Now, so we will quickly go on to the second case. So I have a series of cases, so I want you to understand this, and you have to quickly do the gating and you have to tell me what it is. So this is a 16-year-old boy presented with thrombocytopenia. They did a bone marrow on this patient. Now, which is the abnormal population here?
Left
Can you tell me?
population.
Is abnormal here.
45 dim or negative.
Yes. So what color have I given it to the population?
Yellow.
Yellow.
So the yellow population that you see is a suspicious abnormal population. What is the percentage of this cell? 73. So the first thing itself is very clear that there are 73% cells which are present in this region. That means that something is not normal for sure. All right. What is abnormal? That we will find out later. Now, can somebody tell me the markers here? This is the 34.
19 positive and 10 positive.
10 positive, 19 positive basically means?
Again, B cell.
Again, B cells. What is the 20 here?
Ma'am, 20 is negative.
Very right. What about the 34?
It's
Heterogeneous.
positive.
34 is positive.
Positive.
So again, it's a population of blast.
BLL.
BLL. Okay. Look at the 13.
Yes, ma'am, it's positive. 13 positive and HLA-DR positive.
Right. So, and 33 and 117?
That is, ma'am, 33 is positive and 117 is negative.
Okay. So 117 is clearly negative. 33 is kind of borderline positive. Okay. So
Yes, ma'am.
13 and 33 is positive. So now is it a myeloid or is it
Yes.
a B?
Ma'am, 13 and 33 are basically mild.
Aberrant expression.
Ma'am,
Very
maybe it's a mixed.
Okay, now tell me one thing. So you have seen a 19 and a 10 positive clearly. Okay,
Yes,
and you're
ma'am.
seeing, so you have seen two important markers on B are positive, right? Now you are seeing the 13 and 33 expression is also there. Now, how would you know whether it's a biphenotypic or what is it?
We have to look for MPO.
Okay, so MPO is clearly negative here.
Yes, ma'am.
So, is it
It's
a biphenotypic or it's a B?
a B.
So, why?
It's a
How do
B.
we explain the 1333 expression?
Aberrant expression.
Exactly. So always remember that B cell ALLs are known to have an aberrant CD13 or a 33 expression. So you should not call it biphenotypic. You should call it biphenotypic only if along with the 13 and 33 you also have a cytoplasmic MPO positive. Okay. All right.
Yes, ma'am.
So if this cytoplasmic MPO was positive, we would have called this as a biphenotypic leukemia. But this is clearly a B with a aberrant 33 expression. Okay. Now quickly go on to the third case. This is a 10-year-old boy. He had fever for a week. So the peripheral smear showed atypical lymphoid cells. Now these are all the cases that we had seen while we were gating also. So I explained to you that time also that this was a population which is, so this is the peripheral blood sample, sorry, this is not the bone marrow sample. So clearly you see this population of cells which is suspicious because it is DIM45. Now would you like to have a look at what it is?
Ma'am, this is CD34 positive and HLA-DR positive.
Right,
And then it is CD19 and 10 positive.
right. So makes it like
It's again
BALL. Here the
BALL.
20 is also positive.
And even CD38 is positive.
Yes. Is 38 normally present on the blast? Yes.
And last
Okay.
mostly 34 positive and 38 negative.
Yes. So no, 38 is also positive. 34 is also positive. These are some markers which 38 is usually a marker which helps us in the minimal residual disease when we do it later. That again, we will come back to it later. But as of now, so I just put a 38 here. Like it's not of any diagnostic use as of now. But clearly 20 is positive. The 13 and 33 are negative. Okay.
Yes,
So
ma'am.
it is again a BLL. So I have shown you 3 cases of BLL. Why did I show you 3 cases of BLL? Because I want you to see the position of the B blast on the side scatter 45. So in the first case, the population was negative 45. In the second case, it was dim 45. And in the third case, it was a little moderately bright 45. Do you see the 3 expressions? So, but can you tell me by look, so what happens is, like when you look at the morphology and you want to give a diagnosis, similarly when you look at the side scatter 45, you want to look at the position of the blast and then you want to give a diagnosis whether it's a B or it's a T. So remember that this positions, the first 2 positions are very common in BLS, and this position is not very common in BLL. This is a TLL position when you have a brighter 45. This is generally so when you have a negative 45 generally goes in with BLL, or a dimmer 45 also goes in favor for a BLL. All right. I mean, like this position can be myeloid also, but this is usually B. This is usually T. But here you're seeing the 3 positions which are all B. All right. Now let's have the next case. So this is another patient who had pancytopenia, bone marrow was done. So what do you see? The side scatter and 45. So what you see here is clearly a tiny lymphoid population. Okay, and this is the suspicious blast population. Clearly see. All right, this is 79%. Can you tell me the markers? Are the B cell markers positive or negative? The 19 and 20?
They are negative.
Negative.
They are negative. What about the 3?
Negative.
Ma'am, negative.
Negative. So it is not a B, it is
Or a
not a T.
T.
What about the 1333?
Ma'am, positive.
What about the 117?
Ma'am, that is again positive.
So it's going towards which lineage?
Myeloid.
Light lineage.
Myeloid lineage. Okay. Now we would want to have a look at the cytoplasmic MPO and the CD64 and the monocytic markers also. Because when you are discussing myeloid, you also want to make sure that it is not monocytic. So 64 and 14 are?
Negative.
Yes. What about the cytoplasmic MPO?
That is positive, and
That is positive. So it clearly makes it
myeloid.
myeloid, right? So basically what we have done is, see, I want you to understand the whole concept of it. So B is clearly negative, T is clearly negative, 1333 is positive. So in this case, even, and your myeloid is positive and your monocytic are negative, right? So this is the case of AML. Now let's quickly go on to the next case. This is a side scatter 45. So now this is the lymphoid population, and this is your suspicious abnormal population, which is again 87% of the cells. Now, let's see, who would want to tell the markers? What are the B cell markers here?
Ma'am, CD34 and CD19. The B
Right,
cell markers, and CD34 is positive.
right.
And in the next case, CD34 and CD117 are the markers, where again
Right.
CD34 is dim positive.
Yeah, so it's kind of dim, positive, little difficult to say. So because always remember that 34 positive definitely means blast, but 34 negative does not mean that they are not blast. All right. So the
Yes.
blast can also be 34 negative. So in this case, it's very difficult to say whether it is positive or it's negative. That you will have to do in the gating. But in this case, it is kind of dim positive. All right.
Okay.
Now have a look at the MPO and cytoplasmic CD3. They are
Positive. Sorry. MPO is positive and CD3 is negative. Whereas in the next
MPO is negative here. All right. Just have a look at the MPO. MPO is the entire population is negative.
yes,
It does not have an MPO. But when we look at the 64 and 14, what is it that you see? That the entire
64
population is 64 positive, and out of which there is a smaller population which is also 14 positive. That means that this population, which is 64 and 14 positive, is the mature monocytic population, and this population which is positive is 64 positive, but it is 14 negative, makes it like a pro-monocytic population, and especially when it is 34 negative. So now here you have a combination of pro-monocytes and monocytes, which makes it a acute, yeah, it makes it with a acute myeloid leukemia which has monocytic differentiation. So if you look at the position again of this case, you see that this population is going towards the monocytes. Do you see this? So when we look at the side scatter 45, this graph itself will tell us that it may be monocytic leukemia. Okay? Am I clear? Do you have any doubts?
No, ma'am.
Okay. Now, this is another case. Okay, this is a 23-year-old woman who had come with bleeding gum. Now, this is the case that somebody had mentioned that the center was drooping down. So this was our suspicious population. All right. Now, bleeding gums and with this kind of a thing, can anybody give me a diagnosis?
Ma'am, M4,
APML.
acute myelomonocytic leukemia.
APML. Very right. Okay. So always remember, just don't go by the bleeding gums always. But yes, bleeding gums is a giveaway to tell you whether yes, it is acute promyelocytic leukemia. So remember, promyelocytes are very granular cells. So these cells generally, they are not as high as what the granulocytic cells are. But considering that they're promyelocytes, this entire population actually will look like granulocytes. They will be drooping down. Now, can you tell me what about the CD34 expression on them? Do the promyelocytes have CD33, 34 on them?
No.
No. So they don't have 34. So it is very confusing sometimes because these population will have a 13 and 33 like the granulocytic cells. They will not have a 34. So you will sometimes think, if you don't, you have to see the slide obviously. If you see the slide, you know that they are acute. You don't even need this for the diagnosis. You know it on the slide only that it is a acute promyelocytic leukemia because you will have orods and you will have faggots
I
in a
looked.
diet. Okay. But anyways, you should know how a flow also looks like. And what about the CD13 and 33?
Ma'am, both are positive.
Both are positive. Okay. So do you see the expression of 13? 13 is a little heterogeneous and 33 is very bright. Do you see the difference?
Yes, ma'am.
So this is how normally a very classical acute promyelocytic leukemia looks. If the 33 is bright and the 13 is heterogeneous. Then interestingly, always remember that they are DR negative and they are 117 positive. So the classical APML is which is 34 and DR negative. So whenever you have an acute leukemia which is 34 and DR negative, you should think about APML. All right. And MPO is so beautifully and clearly bright. Okay. Now again, I have put a graph where I have showed you all the cells. Now these are all the acute myeloid leukemias, AML. This is a classical AML. This is a APML. This is a AML with monocytic differentiation. Okay, and this one is actually just like a acute monocytic leukemia where you have predominantly monocytes. So when you see a population, when you see a leukemia which is towards the monocytic, just understand that it is acute monocytic leukemia. So look at the positions on the site scatter 45, and based on the site scatter 45 position only, you would be able to tell whether it is what leukemia. So we had seen the site scatter 45 of all the Bs, and we have seen the site scatter and 45 of all the myeloids. So if somebody gives you just this picture, would you be able to tell that this is an APML?
Yes, ma'am.
Yes, please say yes. Okay. And here also, if you have this, then you can say that yes, it looks like more like a monocytic. Okay, let's now quickly go to the next case. So you have a site scatter 45. So can somebody identify the abnormal population here? I'll just keep marking my arrow and tell me yes or no. Is this the abnormal one?
No, ma'am, small.
Is this the abnormal one?
No.
Is this the abnormal one?
Yes.
Yes.
Very right. Okay. So this population, because it's a dimmer 45 population, is the abnormal population. So I will put a gate around it, give it a yellow color, and these are about 37% of the cells. Clearly, these are 19 and 20 negative. So it's not a B. Clearly, it is 13 and 33 negative. So it's not a myeloid. Now, can somebody interpret this and tell me it's a CD3 negative and it's a cytoplasmic CD3 positive?
T blast.
Yes. Okay. So always remember that the T blast may be surface CD3 negative. Though CD3 is a pan T cell marker, but it may be surface CD3 negative. So don't think it's not a T cell, but the cytoplasmic CD3 will be positive. So before you call anything negative for CD3, always look at the cytoplasm, and the cytoplasmic is positive. That means, and the surface is lost. That clearly means it's a T blast. All right. What about the 34?
Ma'am, 34 is positive as well as CD7 is positive.
Yeah, CD7 is very brightly positive. Okay. So generally TLS have a very bright CD7 and the CD34 is also positive in this case. So even if it was 34 negative, but when you have a population which is cytoplasmic CD3 positive and surface CD3 negative, you know that they are abnormal blasts. Okay. What about 2 and 7?
Ma'am, CD2 is positive and 7 is again positive. Both are positive.
Positive. Okay. So this is what you would expect in a T cell ALS. And what about the 4 and 8?
Ma'am, both are negative.
Both are negative. So basically it's a T cell ALS. All right. 1A, and these are the other markers that we do in T cell ALS, though actually now people have stopped doing it also, but 1A is clearly negative, 99 is positive. So 99 you find it in TALS. All right. So this was a TLS. So now if I show you the populations, okay, B, M, and T, B blast, myeloid blast, T blast. The position of the B blast is usually very dim 45. The position of the myeloid blast is in between this and this. And the T blasts are generally abutting the lymphoid cells. All right. Okay. So if you have an abnormal cell population which is very close to the mature lymphocytes, you should start thinking of T. If you have a population which is towards the negative CD45, you should think about B. If it is in the middle, it can be myeloid. Obviously, it can be B or T. I mean, like any blast can be anywhere. But again, this is predicting the diagnosis based on the size scatter 40. Okay. Am I clear?
Yes, ma'am.
Okay. How many of you do flow? Do you have a flow cytometer in your hospitals where you're working?
Yes, ma'am.
Yes. Okay. So you do see cases every day?
Yes, ma'am.
All right. Okay. So this is our last case for the day. So what I've just done it that this was a patient who was 70-year-old, and this is a follow-up case of CLL. So she used to come every 6 months just to make sure about the lymphocytes. See. So once her platelets started going down, so they just thought that they will do a marrow. Though it was a CLL, and we also thought, I don't know why they are doing a CLL marrow, but anyways, they did a marrow. Now, when we did a marrow, we saw that there are these small lymphoid cells which were very classically CLL, but there were certain cells which were also larger in size. Can you appreciate these cells which are a little larger in size? It's not a very beautiful picture, but still you can see some cells which are larger in size. Okay.
Yes, ma'am.
So obviously, when we saw these larger cells, we thought that maybe it's actually like a PLL transformation which is going on. But
Yes,
since
ma'am.
you have a flow cytometer, you are always tempted to put it up. So this is another picture which shows. Now here clearly you can see that there are these small lymphocytes and these are large blastoid-like cells which are like the pro-lymphocytes, So we put up a flow. When we put up a flow, we surprisingly saw that the entire population divided into two. This is a CD45 positive, and there was a dimmer population, like such a dim population of 45. So we got really perplexed. I mean, like we had just put up a 45, then we put the entire panel. So can anybody, like based on this, can somebody tell me what is happening in the patient?
Ma'am, the patient is getting both B and T and diffuse large B-cell lymphoma.
Okay. Diffuse large B-cell lymphoma. Then anything else?
Even Hodgkin's transformation also can happen, ma'am. Big cells.
Yeah, Hodgkin's transformation can also happen. Anything else?
Man is converted to acute.
Richter's transformation.
Richter's transformation. So, okay, so all the transformations that we've been talking about, remember that, say, for example, let us say that you are saying that the patient is converting into a DLBCL. The population of cells that you're seeing has suddenly become very dim 45. All right. Whenever you see transformations, you do not see such a dim 45 population. They are all, even if it's a DLBCL, they are all very bright 45. All right. The size may go up, but they're all bright 45. So when you see a population which is so dim, it clearly indicates there's a blastic population inside this. All right. When we say a blastic population, we also have to prove that yes, it is a blastic population, because so we have seen two populations. So we have to understand what are these two populations. So we will give them a different color. So the population which is on the bright 45 side, we will give it a yellow color. And this is a suspicious population which we are calling as blastoid. So we will give it a green color. Now somebody will tell me the markers which are present on the green color and the markers which are present on the yellow one. So you have to tell me what is the yellow population based on the markers, and you have to tell me what is the green population based on the markers. Okay?
Ma'am, yellow is CD19 positive
Very
and
good.
CD34. That means it's a B cell population.
That's very right. So it's a B cell population which looks like which is in the lymphocytic region, which is in the bright 45. So this is a known case of CLL. So maybe it is the same CLL population that is there, right? But it is a mature population. What about the green population?
Ma'am, that is CD34 positive and 19 positive. That is again some.
So clearly it is 34 positive. Okay.
Yes,
And when you look at the graph here, it is the dimmer 45 population. It
Yes,
is
ma'am.
clearly 34 positive. It is clearly 19 positive, but it is 20 negative. So what does it make?
Blast.
Very right. So they are the blast of the B cell immunophenotype. So you have a mature B cell population, which is yellow. You have a blastic population, which is green. Okay. Now, when you look at the CD10, what is happening to the CD10?
Positive for blast.
Yeah. So the blasts are positive for CD10, and the yellow cells, which are our supposedly CLL cells, are negative for CD10. Okay. And what about the kappa lambda? I put a kappa lambda here because this is a case of CLL follow-up.
Lambda
So we
positive.
want to see whether, yes, exactly. So they are all lambda positive. So that means that these are clonal cells which are lambda positive. And definitely this is a patient of follow-up CLL, which has CLL. Along with it, there is a tiny population which has converted into now the B lymphoid blasts also. So if I have overlapped this, okay, so the green population is the blastic population, which is negative for kappa and lambda. The yellow are the lymphoid cells, which are positive for lambda. Okay, you can see them here. Again, this is to demonstrate the yellows population. So the CLL population, is it CD5 positive or is it CD5 negative?
Ma'am, positive.
Right. So it might be a little confusing for some people who have not done CLPDs. But remember that the abnormal CLL cells are CD5 positive. So clearly we see the CD5 positivity here and also 23 positivity,
23
which
positive,
shows
yes,
us,
ma'am.
yeah, which shows us that they are CLL cells. And this green population, which was a blast population, is clearly CD5 negative. So you're having two populations. One is that you're having a CLL population and the other population is the blastic population. All right?
Yes, ma'am.
So this patient was basically a B cell transformation. He was a B cell ALL transforming from a CLL. Am I clear?
Yes, ma'am.
Okay. So this was basically an approach to acute leukemias, how you do gating, how do you actually identify the blast. This is for you to have a very basic concept about identifying the disease. If you have any doubts, you can of course ask me. This is my hospital, looks very beautiful, and thank you very much.